Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients. Okay, welcome to the Rehab Blueprint podcast. And as always, we have Giles with us. Welcome, Giles. And then we have Luke. Welcome, Luke. How you doing, man?
Good, man.
Nice to see you got a microphone there, sounding crisp.
Yeah, mate, we're moving up in the world.
So we've done 2 episodes already. If you want to catch those, they're pretty much anywhere you listen to your podcast. So we've been able to get those on most platforms now. And if you want to watch the video rather than listen, you can go to YouTube. And then also we're posting shorts on Instagram. So on the OMT training platform and then on the Rehab Professionals platform, Instagram. We'll go on there, like, comment, engage in some conversation. So today we're going to be talking about osteoporosis and osteopenia. We're going to be touching on a few different things. We're trying to bring as much value and information as we can, so you guys feel like you take something home at the end of the day, and we're trying to keep things relatively short. So anything before we crack into the episode from you two?
No, looking forward to it.
No, we're all good, man.
Brilliant. I'll give a little bit of an intro and then we'll crack on and hear from the lads with their perspectives. So the musculoskeletal system is constantly changing in an effort to maintain physiological homeostasis. Although we think of bone often as this kind of hard, non-adaptable structure, I think a lot of people think of it as that. It is continuously reacting to the environment through load, resistance, and movement, right? It's key that we understand that, causing a cycle of remodeling, building up, breaking down, and reabsorbing. So osteoporosis, for the purpose of this podcast, is going to be defined as significant thinning or weakening of bones over time, making them vulnerable to breaks. And osteopenia, if it comes up, is going to be a mild thinning and weakening of the bones, or bone density is lower than a normal, but not low enough to be classified or diagnosed as osteoporosis per se. So hopefully that's clear, setting the stage for everybody for the podcast. We're going to touch on a few hard truths. 1 in 3 women and 1 in 5 men over 50 globally suffer from osteoporosis. Men lose up to 1% bone mineral density per year, with 1 in 8 experiencing an osteoporosis-related fracture in their lifetime. Over 200 million affected people worldwide. More common in postmenopausal women, around 25 to 30% prevalence. Normal bone mass starts to fall beyond age 40. Bone mass has reduced by 30 to 40% by the age of 70, so that's quite significant. Low bone mineral density, so LBMD related deaths such as osteoporosis, have increased by 148% from 1990 to 2019. That's an interesting stat, right? Because we're looking at lifestyle factors. We're looking at other potential risk factors, which we're going to touch on. In the US alone, there are around 300,000 hip fractures per year, and these result in medical expenses exceeding $9 billion. So by 2040, that is predicted to double. So it's a significant weight on the medical system. A hip fracture can have disastrous physiological effects and obviously psychological effects, which is one thing people don't maybe think about or look into. A recent study reported 80% of women would prefer to simply pass away in their older years than be placed into an institution because of a hip fracture. The 2 main risk factors for hip fractures are falls and decreased BMD, which is bone mineral density, but we're going to go a little bit more into that soon. As I said above, it's important as rehab professionals we understand the function of bone remodeling is to adjust to the architecture and meet the changing of the environment. Bone remodeling also helps to repair microdamage in the bone matrix, prevents accumulation of older bone. Additionally, bone remodeling aids in maintaining plasma calcium homeostasis. So it's quite an important thing. Anatomy 101, physiology 101, take you back to school first year. Osteoblasts, cells that build bone tissue. Osteoclasts, cells that remove bone tissue. Osteocytes, a cell that's embedded fully in formed bone. Now that we have a little bit of an understanding of the prevalence, a few stats and what it is, and the terms of what we're going to be talking about, I want to ask Giles, someone that has educated professionals worldwide, and you have ran clinics yourself, you've got extreme clinical experience yourself. So Giles, could you talk to us a little bit about where this fits in with manual therapy? So are there contraindications? If so, when, how, why? And what are some other strategies to go along with that?
Are there contraindications of manual therapy? Absolutely. There is no, right, and it's really important. There is no technique that is risk-free. Nothing is risk-free. Soft tissue work has risk. Mobilization has risk. MET work has risk. Manipulation has risk. It's just on a sliding scale on things that we may be able to look at in regards to case history and discussion and trying to mitigate some risks. And there's also a selection of risks that we may not be able to ask questions about, that may be underlying that we might not be aware of. Again, a lot of it's down to sort of patient examination and questioning, but there is always going to be risk with technique. A lot of it's going to be down to the specific technique in question that we then have to look at whether it is appropriate or not appropriate for that person, if that sort of makes sense. Yeah. What was the other question? I can't remember now.
The discussion around contraindications, absolutely what you're saying makes complete sense. What about specific to osteoporosis? So you have someone come in who's older and you've done your case history, this and that, and either they have a diagnosis of it or you suspect it.
All right, so you got two things here, because let's be fair. When does osteoporosis tend to get diagnosed? Right, it tends to get diagnosed once a patient's been fractured. Once there's been a traumatic fracture or a fracture or a repetitive fracture, unless they have maybe family history and they've gone through sort of scanning and imaging as part of a screening or a health check. So there's two different things there. So if a patient comes in to see me as a therapist and they say, I have osteoporosis, it's a massive tick for me in regards to the techniques I am not going to use, because ultimately you're there to try and help the person feel and move a bit better. We're using manual therapy for its ability to help them feel and move a bit better, reduce their pain. So therefore, there's no point in using techniques where the risk of the technique is not worth the reward of the technique. So you end up moving away from anything that could potentially compromise the bones, such as manipulation being like number one. So if the patient comes in and they have a diagnosis of osteoporosis, I am not cracking them. It is simple as that. It's not worth my license, it's not worth my mortgage, and it's not worth being struck off. So one of them, an osteopath, you can read about it in the General Osteopathic Council disciplinary process. He was struck off because he did a thoracic manipulation on a patient who was osteoporotic. So it's a complete contraindication from an ethical perspective and from a professional perspective. So if you're using techniques on patients and it's clearly inappropriate, you are going to get struck off, or you're going to put yourself at risk of being sued. Now, if the patient is presenting with potential symptoms that they may have osteoporosis, they are frail, they are elderly, they have it's very, very slim, they may be on like medications that predispose them to osteoporosis, then I'm going to act on the side of caution. I will use the minimum amount of technique to achieve what I want to. And that's why having a wide skill base is really, really important. If all you do is crack something, then that's what you're going to want to do to everyone, whether it's appropriate or whether it's not. If you know how to do soft tissue, mobilization, other modalities, exercise, rehab, the whole lot, a widely skilled practitioner, then you can pick and choose, use the appropriate techniques for the person in front of you. But remember, you will never be criticized for being cautious and safe. If you just Y-strap every patient, regardless of what they come in with, at some point you are going to get in trouble because something is going to happen. You will only ever be sort of criticized if you are cavalier, if you aren't asking the right questions. And there's no point in putting yourself and your professional title, your professional license, your finances at risk for what is a technique that may help and make the patient feel and move a little bit better for a short period of time. Always act safely, ethically, and as gently as possible with the patient until you see how they respond to treatment.
So it's interesting there because you touched on when do we actually know if they have it, right? And you're like, okay, well, they've come in and they've had a fracture or they've got a diagnosis from a medical doctor and you understand it's on their charts, et cetera, et cetera. However, there are a lot of people that will come in, maybe at older individuals that have this kind of osteopenia. So we're looking at this thing that's a little more mild than what would be potentially classified as osteoporosis. In that situation, what would your take be? Now, I'm going to assume you're still not going to do HVLA, but I am interested to know, is LVLA, is anything that's acting on the joint going to be appropriate in that situation? Or are you going to move more towards soft tissue?
No, right. I think osteopenia is on a spectrum. I think it's on a wide spectrum. And right, so osteoporosis and osteopenia are on a spectrum because you can have osteoporosis and be able to deadlift crazy weight, squat crazy weight, live your life, do your thing, be robust as anything, and you may think manipulation is completely appropriate. Okay, that's fine. But you can have osteoporosis and be as brittle as balsa wood. That's when a technique is completely inappropriate. So it's on a very big sliding scale.
Yep.
Same with osteopenia. You cannot just say because you are osteoporotic, it's completely a no-no. A lot of it is down to your knowledge, your experience. It's about your understanding of the condition, and it's about case history. It is all about questioning the patient, because two people can have the same condition. One person can be totally appropriate for a manipulative technique, for example, and another completely not appropriate. So this is why case history, in my opinion, is so massively important, and also understanding your scope of practice. So if you are a massage therapist and you have a patient with osteoporosis, then if you're unsure, refer to a practitioner with more experience and more knowledge than you have. Don't use techniques that you're unsure of. Don't use techniques that are potentially risky or compromising the patient. Err safely. So if in doubt, refer. But remember, these conditions are on a sliding spectrum, and a lot of it's probably down to common sense, good clinical thought process, case history, and individualizing that treatment to that person.
So we talk about case history, comprehensive assessment, critical rationale, critical thinking, clinical rationale, all these things that are so important for any rehab professional or any practitioner or clinician. And that is true. But when someone walks through the door, what are some of those risk factors that we need to be aware of? This question's going to you, Luke. What are some of the risk factors, and what are some of the questions, or how important is this history in really ascertaining what we're dealing with and where they are on this sliding scale of osteoporosis or osteopenia?
Yeah. So when it comes to risk factors, we're looking at two categories first off. And we've got the non-modifiable risk factors, which are things that the person can't change. So we're going to be looking at things like general aging, genetics, ethnicity as well, certain medical conditions, autoimmune diseases that they've been diagnosed with. And then we're breaking up second category into modifiable risk factors. So these are the things that don't necessarily have causation effect, but they have a correlation combined with other factors along the way. So we're going to be looking at things like nutritional deficiencies, lifestyle, like just general physical exercise. Do they smoke? Do they drink a lot of alcohol? Any types of medications that they may be taking are going to play a massive part. So just to touch on a few of them to begin with, if we start up at the non-modifiable risk factor section, when it comes to just looking to general aging and bone health, we know that the older we get, around that 45 to 50 age bracket plus, bone reabsorption and bone formation is naturally going to decline. When it comes to male, female, we also know that women have a naturally faster rate of bone loss, particularly during that postmenopausal range due to, hormonal factors, estrogen decline, all that sort of stuff. Men, not so much. Again, can lead to, due to a slower gradual decline in testosterone, just with men in general, like things can be often underdiagnosed or undertreated as well. In terms of genetics and ethnicity, family history is going to play a massive part. If you have family members who have osteoporosis, also that higher increased risk in fractures due to different structures within the bone. Ethnic differences, we know that there are a difference when it comes to that. So naturally, Caucasians and Asians are going to naturally have a lower bone mineral density. This is just due to the environment potentially as well that they may live in. And then when it comes to Africans and Hispanic population, naturally they'll have a higher bone density as well. In terms of medical conditions that individuals may have, such as autoimmune diseases, we know things like rheumatoid arthritis and lupus are also going to increase the osteoporosis risk factor. These may be things from general inflammation, corticosteroid use that's prolonged over time that can affect bone mineral density as well. Other conditions, hypothyroidism, diabetes, all that sort of stuff, are naturally going to have a factor as well. When we move on to some of the modifiable risk factors, which are things that obviously we can change. When it comes to nutrition, we know that calcium and vitamin D deficiency is a massive factor. Obviously, calcium essential for bone formation, and vitamin D is going to regulate calcium absorption within the system. So this just comes down to general diet, making sure you're getting those micronutrients within your diet, a certain calcium daily recommendations, as always, as well as vitamin D2. So that's going to be things from sun exposure, which is the main sort of factor for that vitamin D. And then looking at the main one that we're probably most concerned about is having a sedentary lifestyle and making sure that we are getting enough weight bearing and resistance exercise. So as Brogan touched on previously, we know that bone adapts to stress. So without any sort of resistance training or even just general low impact training, bones are naturally going to weaken as well. So that is probably the most important concept to take away for that one. We have a lot of research on it when it comes to looking at studies of how much resistance training and low impact exercise is necessary in order to improve that bone health, which Brogan will touch on soon. And when it comes to looking at smoking and alcohol use, we know this is a massive one. It's naturally going to impair bone formation, reducing that osteoblast activity that Brogan touched on before, and also increase levels of cortisol too, which is going to promote bone loss overall. And there was actually an interesting study, a 2023 study found that heavy alcohol consumption, more than 3 drinks per day, was linked to a 68% increased risk of osteoporosis. So that is huge. That is massive. Again, it's going to vary from individual as well, depending on the standard of drink you have, the percentage of alcohol. But we know if we can try to limit that intake overall, then it's just going to be better general overall health down the line. And then a couple of smaller ones as well, looking at medications, I think that we sort of touched on before. So probably corticosteroids, is the most important one that is going to affect that bone density. And then there are some very low evidence research based factors too, environmental factors, looking about air pollution and environment and exposure to green spaces as well. But I don't think we'll touch on that too much. So to sum it up, like I said before, it's important that we screen. Not only do we screen individuals for these factors during our new patient consults, our histories, but take into consideration that one factor does not lead or cause to this. It generally has a compounding effect with the other risk factors.
Yeah, I mean, that was real comprehensive, so good job explaining all that. And a lot of that we've heard, people listen to that, I'm sure you've heard all this. You kind of learn it early on in university. I think those risk factors can sometimes be overwhelming. So I think one of the important things is to obviously make sure you have a good overall understanding of what they are, but just make sure that you've got it all covered in your paperwork as well, and make sure that you're being very detailed, covering it off and going through that in your history. Again, we loop back to the importance of the history, right? So we've talked a lot about those risk factors. It's that compounding effect of someone's lifestyle. Someone walks through the door, they fill out their forms, you're doing your assessment, you're doing your history, you're starting to notice a pattern. It's making sure that you're exercising some critical thinking, some clinical rationale, and applying a treatment that's going to be not the most invasive treatment. And I've heard you talk about this as well, Giles. In fact, it popped up on my feed literally this morning. And you were telling a bunch of students about it. Do you want to talk about that real quick, about applying minimal effective dose, really, is the concept, isn't it?
Well, I think I'm a believer in less is more. So basically treating the patient as an individual and using the least amount of technique to get the most out of it. Yeah. So, and especially when you have a new patient that you're not sure about, it's always worth to test the waters with techniques such as soft tissue work, maybe MET, maybe mobilization, before you start using more robust techniques, because it can be very easy to chuck everything at a patient, and then you don't know what's going to work. And also there's a theoretical risk that you sort of hyperstimulate them. But I think the importance for me is case history, case history, case history. If something goes wrong in your treatment room, whether it's at the time or subsequently, your governing body or that legal team is going to take those notes and read what you've done. They want to know what questions you asked. They want to know what questions were logical, what the presentation was. And if you don't do a thorough case history, you are putting yourself massively, and I cannot understate this, massively at risk. It's just not worth it. And so there is a tendency when you get into practice over a longer period of time, common things happen commonly and your case history gets less and less and less and less and less. That familiarity breeds contempt and it puts you in a very dangerous position. You have to be constantly checking yourself, checking your ego and making sure that you are not falling into that I'm so clever, common things happen commonly, I've seen it all before. Yeah. Treat as I find, and then something goes wrong. Because hindsight is a very valuable thing. And literally, we are there as facilitators to empower the patient to heal themselves by using interventions, manual therapy techniques, exercise, education, etc., etc. So I would never be able to forgive myself if I caused the patient more harm by them coming to see me through my ego and ignorance.
Yeah, it's about being patient-centered. And I know we always kind of talk about this, but we're going to say it and say it and say it over and over because it's true. And what we tend to see on social media, or what even I tend to see in some friend groups, is not what I would call patient first treatment or care.
Hey, I see those videos on social media of those elderly ladies or elderly patients being manipulated and absolutely snapped in half by crazy high velocity, high amplitude techniques. And my thoughts, you're right, it's not patient-centered, it's self-centered, it's clickbait, it's a torturous, brutal, grievous bodily harm on a patient who's incredibly vulnerable. Yeah. And it's just, you look at that and you think, oh my God, why is this therapist not being prosecuted for assault?
We see it on social media, but like I said, you also see it amongst your peers. What I would consider unethical, a lot of it you see in the chiropractic world. I'll speak to that because I know a little bit more about it than osteo. They put them on these wellness plans and they'll get people on these kind of subscription models. I remember when we were at university, me and Luke heard a story from a chiropractor that talked about how he did like a survey of his patients to see how long they thought they were being treated for. Correct me if I'm wrong, Luke, but from memory, I think they thought they were being treated for about 10, 15 minutes. But he was actually sticking to a very strict protocol of 2 minutes.
So, and this is not uncommon. So how can you safely evaluate a patient in such a short space of time? And the question is, I did a 2-hour new patient appointment when they first came in. Yeah, but things change. Stuff changes, new things present themselves. So doing a thorough case history at the very start and then doing bog standard, Billy Basic, tick the box questions every time they come in subsequently is still putting yourself at a huge risk.
And we also know it's not a 2-hour initial. We know it's 30 to 45 minutes max, and 10 to 15 minutes of that is giving the chiropractic spiel at the end. So in terms of assessment, it's probably 20 minutes.
What you're seeing is a business model set up to make revenue, to make money. It's a business model. It's not patient-centered, in my opinion. They can easily hide behind what would be a subluxation model, because within those 2 minutes, some of these universities are trying to teach you to do what they would call is a assessment package so fast so that you can locate the subluxation and then treat it. And that is the foundation, the basis, based on 140 years ago, D.D. Palmer, that is the basis of subluxation theory, which is the basis of the chiropractic profession. And I know it's growing, and then there's people that are doing evidence-based stuff now throughout the world. But in our experience and what we're dealing with here, throughout Oceania, there's a lot of more traditional stuff still happening. They use that to justify those shorter appointment times because they're doing a assessment looking to locate, analyze, and facilitate the correction of subluxation. And what I just said then, you'll notice I said a few very specific words. And why? Because we were taught that over and over and over. Am I right, Luke? So locate, analyze, and correct the facilitation of subluxation. So that is how they get away with it in some ways. So I don't want to go too far off, but that is extremely, the reason why it's pertinent to this episode is because we're discussing the importance of history within the context of osteoporosis, right? But that, in my opinion, is also unethical.
So it's not just chiropractors; it's happening across all professions. And I saw, I sent you a clip of this muscular guy cracking the neck of a guy in the street. You know, and I'm like thinking to myself, you've just basically assaulted someone in the street. You know, that person could have an underlying cardiovascular issue. They could have bone weakness issues. They could be on the brink of a AAA, and you're lumber rolling them on the pavement. You're cracking their neck on an aeroplane. I mean, my goodness, it's the ego, the ignorance just blows my mind on how, and I feel sorry for the patients. I feel sorry for these people believing that these people are there for their to help them. And the reality is they're only there for their self-interest. It's narcissism and vanity, and it's putting people at significant risk.
A good way to sum that up, right, is that you're taught that it's a way of life for everyone, you know, from the moment you're born to the moment you enter into retirement and you're heading into your 80s. Chiropractic is for everyone. That's essentially what it is, right? So they kind of see chiropractic there is ways of doing a different adjustments, manipulations. You know, you can use activators, you can use drop tables, you can use that all sorts. So they tend to try to differentiate or vary those treatment methods depending on where you are at which stage of life. So, but still, you know, when it comes to a drop table, if you set the setting too high and you thrust Pete away on that, like, you can still cause issues. So
yeah, there's no question that we're not here to attack a profession. We're simply saying there are protocols, there is a system that you should be following. There are questions that you should be asking, right? There is a way to do this that is both ethical and humane, as you said, because if you're just cracking someone in the street, not only is, like you said, borderline potentially assault, battery, I think is the actual word for it, right? But the issue at hand is you've just completely pulled the rug out from under your profession. All of this,
your whole education is in the bin.
You're just cracking somebody with no prior thought process and no specificity of treatment. It is, to me, when I see those videos, again, it's not patient-centered. It's self-centered. It's business-focused. It's social media focused. It's trying to put something into this algorithm of social media that it's going to benefit you, because the average person likes to see it. You know, like the average person likes to see someone get cracked on social media, especially in tight yoga pants.
Like I said, I don't have an issue with any technique. There is validity in all techniques, but for the right person at the right time, for the right condition. And that's where clinical judgment comes in. That's where common sense comes in. That's where thought process comes in. And if you're not asking the patient the correct questions, I am concerned how many patients are being treated with underlying health conditions that that could have been picked up, that theoretically are putting them and the therapist at risk of compromise. Again, I was saying to Brogan, I've been changing my social media algorithms. Every time a thing pops up, it's some crazy person doing something stupid, I try and dislike it, and because I just don't want it on my feed. The amount of times I'm seeing now coccyx adjustments, just like, it's blown my mind. Like a couple of months ago, everyone was sticking balloons up their noses, when the reality is just get some Vicks vapor rub, or some menthol crystals. They'll do a much better job. Or they're like yanking skin, trying to crack that. Or now it's like coccyx. Everybody is freaking giving it large on the coccyx. I don't know what this 2025 coccyx is. It the year of the coccyx? I don't know.
I have to ask, did you learn a coccyx adjustment in school?
We got offered it, and I said no. So our year, basically, when you get to the 5th year, they said, look, do you want to learn this technique? And I'm like, seriously, mate, I don't get paid enough money. I'm an osteopath, right? I'm not a proctologist. I'm going to refer the person who knows about that stuff much better than me. I'm an osteopath. Come on, man. It blows my mind. Refer. Stick to the MSK, just stick to what we're allowed to do, and don't go outside of your scope of practice.
Anyway, so to circle back to osteoporosis, we have covered various things, but we want to bring solutions on this podcast. We don't want to just talk about problems. One of the most common and well-researched solutions is going to be applying load, resistance training. So when we think about the basis of what would be Wolff's Law, so for those that don't fully understand Wolff's Law, it's the idea that bone is kind of always changing, right? So the remodeling process of the bone enables it to respond to external stimuli and kind of its surroundings, the environment. So Wolff's Law states that bone forms and gets stronger along mechanical stress lines. The implication is that, like most bodily tissues, bone atrophies in the absence of stress. So when we talk about the requirement of load, how much is enough? How little is too little? How much is too much? And luckily, we do have quite a fair amount of research on this. One thing that I like to look at that the American Bone Health Organization discusses and has done some research on is something called the osteogenic loading index. And it's not super complicated. It's quite easy to understand. I'll put it up on the screen right now. And what we're kind of getting here is this spectrum of what would be the amount of bone formation by exercise by looking at the magnitude of load times loading frequency. So down the bottom, we have something that would be like cycling or swimming, which is very low. And then above that would have walking, and then we'd have brisk walking. And then above that would have running and jogging. And then at the top would kind of have strength training and jumping. And so the idea here is that it's like the force velocity curve, right? So you're either going to stimulate remodeling and you're going to stimulate osteoblastic activity via force, so that's load, or via power, so like high velocity and power movements. It's not just necessarily about lifting weights, but you can also do other things that are going to create a bone matrix response, which could be like plyometrics or jumping or various things like that. The problem with some of these lower level exercises in terms of lower load, lower power, lower velocity is that you may not be doing enough, but it's knowing when. Because obviously if you've got an elderly person coming in to see you, you need to ascertain based on your clinical rationale, your history and your comprehensive assessment, how much is too much and how little is too little in terms of what you're going to prescribe. So I don't want to say walking's not enough, because for some subset of the population, walking may be appropriate, and there is some research showing that walking in the long term may actually help improve bone density. However, we want to be using that as what would be a way to get them into a program that we can then build upon and improve to get them to a point where they're potentially doing a little bit more load, whether that's banded exercises, body weight, and then all the way through to isotonic movements or isometrics with actual load. That's going to yield more effective results. One thing I wanted to touch on before we start to close up is why resistance training is so important. And so we can see when we look at the literature, the research has consistently found strength and resistance training to be extremely promising and effective as an approach to address the loss of muscle and bone caused by osteoporosis and sarcopenia, which is another thing we haven't necessarily touched on, but it's along with similar lines, right? Loss of atrophy of muscle and loss of muscle. In order to kind of promote the osteogenic effects necessary for the deposition of bone mass and bone tissue, it needs to be subjected to mechanical loads that are appropriate, which we just touched on. So let's look at a few research studies and then we'll move on to some takeaways. A 2013-14 randomized control trial found that heavy squats, so 85 to 90%, so it's quite heavy, to be very effective strategy for increasing bone density. That is expected, right? That's for the lumbar spine, the hip, the femoral neck, respectively, etc. But as little as 12 weeks, so you're getting quite a high amount of return for a short amount of time. So heavy lifting, we know it's going to work. But is it appropriate for the person that's walked through your door? Potentially not, right? So we're going to keep that in mind. In postmenopausal women, 6 weeks of low repetition, light load, but power training improved pelvic bone mineral density and knee extensor strength. So that's what I touched on before about looking at the force velocity curve and power equation. Another study in postmenopausal women, a 5-year program of weighted vest training and jumping exercises that helped maintain bone mineral density and help prevent further loss, so potentially not enough to increase, but to maintain. That's another thing that we got to think about. A 2022 study reported that strength training protocol of like 6 reps, around 70% of the 1 rep max, was significantly effective at improving BMD as well. That was over a 6-month period. Another study of 222 premenopausal women, this is the one I wanted to touch on, which is quite interesting, reported brisk walking as an effective way of improving bone mineral density. So they did an ANOVA, which is a way of comparing statistical significance of data to compare each group within that study, and they were able to see an increase in bone mineral density between groups over a 2-year period. Interesting. And then last one I want to touch on is a randomized control trial of 102 women. They reported a slight increase, however, statistically insignificant improvement in osteoporosis following 12 weeks of elastic band training. So a slight increase, but in terms of like statistical significance, didn't quite reach that threshold. Any thoughts on what I kind of just presented to you guys?
Well, I think it's common sense, really. Like I always say, what the patient does off the table is more important than what we do on it. So, use whatever manual therapy techniques you want to, as long as they're appropriate for the person, get them feeling and moving better, and then get them training as fast as possible. It seems to be, yeah.
In a situation like this, where you've had somebody come in that's expecting manual therapy, they want a rub or needles or a massage, or they want to be clicked, but you have, throughout your comprehensive assessment and history, you're seeing some risk factors and you think that communication and education around utilizing exercise to improve their bone mineral density moving into their later years is important to do, how do you go about that conversation?
Yeah, I think it's just important to first off begin with some of that education, running them through those risk factors that we mentioned previously in the pod and linking them up to making them applicable to what that individual may be presenting with, right? So if you identify that there's no level of exercise or resistance-based training in their week, they don't touch on too much of a diet. It tends to be, what they feel like might be a cup of tea for morning tea and then a little bit of a sandwich for lunch. It's important to be able to recognize particularly those factors where you then may refer on to a further health professional, a dietitian, a nutritionist, something like that. So I think in the initial session, it's important to touch on those risk factors and why you are moving away from a specific treatment for the meantime, why you might be focusing on something more like exercise-based initially. And I think as long as you lay the ground terms from the get-go, then they know that you're actually serious about what you're talking about versus just pushing that ball to the side, just getting stuck into the dry needling, the adjustments, the soft tissue anyway.
Yeah, you can also refer to their medical doctor, their GP, and you can also, if you've got some information on hand, if you work in a clinic where they have like pamphlets and stuff like that, it's always helpful to have talking points and to be able to follow that up and give them something that they can potentially take home and read through as well if you think there is risk factors or a potential problem there for osteoporosis or osteopenia. What are your thoughts on that, Giles?
So the question is, how would I approach it if a patient wanted purely manual therapy and I believed that there was a contraindication and I didn't think it was warranted? Is that right?
Yeah, and you wanted to have the conversation about how they probably need to start implementing exercise so that they can improve their bone mineral density.
In relation to the first question, if a patient comes in, they're paying for my knowledge, they're not paying for my techniques, they're paying for my knowledge, and it's my clinical process. It's my decision what techniques I will or will not do because it's my insurance and my license. So if the patient comes in demanding a specific technique and I'm not prepared to do it, then they'll be asked to leave, basically. I'm not prepared to compromise my insurance or my professional license just to make someone feel better or feel happy. So I'm very strict on that. And I do believe that as a therapist, you need to have a very strong line and one that you're not prepared to cross. So I'm only going to use a technique that I believe is appropriate. If I believe that they need to engage in nutrition changes, lifestyle changes, or exercise, then I'm quite honest with them because I would appreciate that myself. So I'm not going to sugarcoat it. I will say to the patient, look, you need to do X, Y, and Z because of this. And I think honesty and transparency is incredibly important within our profession because we are primary healthcare practitioners, we are healthcare professionals, we do work in a wider medical community. I don't go to my general practitioner, my doctor, and he sugarcoats it. He tells it to me straight. And so when I have a patient, I'm exactly the same. I believe in honest, ethical, appropriate communication with the patient, not fear-mongering, not pseudoscientific. If I don't know, I don't know. And I believe in being as honest with them as possible. And I think that's something that I've always taken away from my previous experiences and how I treat my patients.
And if you're an allied healthcare professional or a massage therapist or a personal trainer or you're something where you're not a primary, then you can also encourage them to obviously discuss this with their GP as well or their medical doctor, like I said before.
Referral is key, isn't it? Referral is key. If you don't know, refer.
Absolute wisdom. So I'm going to touch on some key takeaways that I want the listeners just to keep fresh in your mind as you go throughout your day after listening to this podcast. So number one, heavy load and power training seems to have a positive effect on increasing bone mineral density, but may not always be suitable for an elderly population. This is something we need to consider and we need to exercise some clinical rationale. Finding safe strategies to increase the load safely over time is obviously going to be key. You want to implement the right thing at the right time for the right person. Lighter work may be effective when power is high, weighted jumping or dynamic movement, for example. Loads that are too light, such as resistance bands or no load at all, seem to obviously have less of an impact, and although are still important, may not be as effective. They may be, however, suitable to maintain one's bone density or be used as a progressive strategy leading to heavier loads, as we discussed before. Walking seems to be an efficient option to improve bone mineral density over longer periods of time and is a really safe place to start for many. However, depending on the volume times intensity, walking may not create an adequate stimulus to increase bone mineral density. So it's really understanding the person that's in front of you and figuring out where on that spectrum you want to start, ensuring that you are giving them a plan that is going to be progressive, but also safe so that they're not going to do further damage. I think a lot of it is common sense, but sometimes for us clinicians or practitioners or therapists, we know it's common sense, but it's nice to listen to a podcast. It's nice to hear the stats, hear the research, hear from some other clinicians and practitioners to give us a little bit of confidence. So my hope is that our discussion today gives those of you that are listening, gives you just that, a little bit more confidence and a little bit more of an understanding. The reason why we all come from three separate professions, a chiropractor, an osteo, and an exercise physiologist, but we converge on so many things, is because we're converging on what we consider to be evidence-based practice. That's why we can, as Dr. Locke would say, lose our religion. That's why we can put down our titles and we can come together and say, what is best for the patient? How can we do what is best for the patient?
Look, the reality is that there's more similarities now between professions than there are differences. We may have some slight historical changes and historical differences and slight philosophical differences, but it's 2025. I think the best therapist is a therapist who can leave the ego at the door, put the title away, and learn off all healthcare professionals, because ultimately our goal is to help the patient. Our goal is to get them as best as they can be, as fast as they can be. And that's the only way we're going to do that is through corroboration, collaboration, sharing knowledge, sharing skills. And we don't do that if we're insular in our own little echo chambers with people that follow the same ideas as us. The only way we grow is by challenging. The only way we grow is by being wrong and learning from our mistakes and getting better. And we do that by working together. As it's cliched as it is, teamwork makes the dream work. So I don't call myself an osteopath anymore. To be fair, I call myself a manual therapist because I've had the pleasure of working with so many other professionals, seeing the flaws in my profession. I think collaborative therapists' knowledge and skill is the only way that we can really progress forward. So yeah, leave the ego at the door, leave the title at the door.
And is the osteo course on your platform, is that free?
Yeah, it's totally free. So on ONT training, we have a free course on osteoporosis, and it covers everything that we've talked about, as well as exercise rehab and clinical thought process and appropriate techniques and manual therapy discussions. So it's all free for you to access anywhere in the world. It's all free.
Yeah, so if what we talked about today piqued your interest, or you feel like you have inadequate knowledge on it and you want to do a little bit of update, by all means, head over to OMT Training, and it's free. Check it out, sign up. Like Giles said, it's fairly comprehensive. I was involved with the project as well. Everything we touched on today is in it and more. So there's really no reason not to. And as I like to say, we're not here trying to sell you anything. It's free. It's free. Go over, take the course, enjoy the course.
Or don't. It's fine. Don't worry about it.
It's fine.
Or don't. It's no worries.
And then apply that knowledge to your patients and, get up, go see your patients, get them better, do good work. And be a part of your community. That's really what we want to see from rehab professionals around the world. Anyway, Luke, is there anything else you want to add before we close up?
No, that's all good, man. Covered it all. It was another great episode.
Brilliant. Giles, you happy?
Awesome, man. Good night, guys. Thank you.
All right, it was a great podcast. Thanks for listening, everyone, and we'll see you next week. Each episode, we're going to dive into evidence-based strategies, cutting-edge research, and real-world insights to help you elevate your practice and empower your clients.